Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 213th episode of the CodeCast podcast today. My name is Terry Fletcher. I hope everyone is having a good November and that you started your Christmas shopping. Yes, I said it. And also your Thanksgiving gathering. It looks like this year everybody's going to get back together and be able to have some good Thanksgiving family time and friends time. And I'm looking forward to that as well. I actually even get to visit my daughter in the next couple of weeks in Arizona. So here we go, and let's see what we can do with our topic this week of what can a medical assistant do and not do. So I'm going to open with kind of a funny story. You're going to think I'm doing one of those jokes that says, I walked into a bar last week, but let's not joke so much as far as basically pivot to what actually happened. And that was I walked into a physician's office and I just need something minor to have a discussion about. And it was and I never go to the doctor, let's face it. But when I do, I want to have a conversation. And I just remember after talking to the physician, he said, okay, my nurse is going to come in now. I'm like, okay, great. So then I'm talking to the medical professional that came in. And I said, now, are you a nurse practitioner or an RN? And she goes, oh, I'm a medical assistant. Okay, well, after my head spun around and I started, freaking out a little bit, I said, oh, the doctor referred to you as his nurse. So I just made the assumption that you were an actual nurse. Not to be snarky, not to be mean, not to be condescending, just to be actually showing my surprise that the reference of nurse was made. And she said, I know, he always does that. So being who I am, and those of you that know me, I don't hide anything. I don't hold back. I said, okay, can you have the doctor step in when you get a chance? And she goes, is he in trouble? I said, he's not in trouble, but we definitely need to have a conversation. And she's like, okay. And she goes, I didn't do anything wrong, did I? I said, no, you didn't do anything wrong, mainly because she didn't do anything yet. So the doctor stepped back in, which seemed like what was waiting forever. And I knew he was like, oh, shoot, it's Terry. What am I going to do? And he knows what my profession is. And so he came in. I said, I just want you to know I'm not chastising you. All I am is warning you and giving you a heads up that this is something that not only do I podcast on as a professional expert in the field, but this is something that gets picked up by a lot of different entities. I talked about it on ICD-10 Monitor, and AHIMA, American Health Information Association, picked it up. And there's, AMA picks up a lot of the things I do, and it just kind of keeps going. OIG monitors what I'm talking about. And all I'm saying is that if you refer to a personnel in your office as a specific professional, as a nurse, that person better be a nurse. And they can't just play one on TV. They actually have to be that professional, because when you reference nurse, they also are medical decision-making professionals, and a medical assistant is not. And so if I had asked her a medical question and she responded and giving me medical advice, you would have been in big trouble as far as violating what a medical assistant can and can't do. So I just wanted to put that out there, because that is not something you want to be caught with. And he actually appreciated my candor and said, I will watch that next time. I actually never really thought about it, because patients just assume that everybody that comes in, he said, is a nurse or somebody that's not a doctor if it's not me. And I said, and I can see that, but you have to be careful. So here's what happened also in New Jersey, which actually triggered this conversation when I talked about it I only get 4 minutes when I talk about my live spot on Talk 10 Tuesday with ICD-10 Monitor. So I like sometimes to then expand on that topic on my own podcast. So one of the things that came up was in a recent grand jury indictment, 3 defendants, a doctor, a medical assistant, and an office manager, they all worked together in the same practice, and they were actually charged with conspiracy because of fraudulently billing for the medical assistant services. Now, the trial court dismissed the indictment, saying that the prosecutor failed to adequately and accurately instruct the grand jury about what a medical assistant could do without encroaching on the licensed practice of medicine. But then this case went to the appellate division and it's still pending. And they're looking for more violations of statute on what's going on with that. The case is still pending, but now with the more frequent use of medical assistants, especially with some of the losses that we're seeing with nurses because of the mandates that are out there, this presents some unique questions for the healthcare industry as a whole. And what services, this is a question in your practices that you need to ask, what services exactly can a medical assistant perform under the supervision of a licensed physician without encroaching upon the practice of medicine? This is really an important question. Medical assistants have a very narrow list of things they can and cannot do for patients in a doctor's office. It's often difficult to know what this list is because there's not strong laws regarding medical assistants in place. There's actually a medical assistant website as well for their association. And I was recently speaking to the attorney on this that runs the website, and he said it is very tough because you also have state issues. But exactly what happened to me in a physician practice, many physicians refer to their back office staff as a whole as nurses, and I'm air quoting. And this general term can range from actual RNs to an NP, which is a nurse practitioner, to an APP, which is an advanced practice provider like an NP or PA. But it also has been used to refer to the physician's, back office staff like a medical assistant, and that is incorrect. That gives a false impression to a patient that this is a medical decision-making professional, and we need to be clear, they are not. Now, there's no specific current federal rules for MAs, and it's imperative that practices read up on the state rules because the federal government is starting to get involved, and each state has different rules. So the profession as a whole is actually lacking a unified scope of practice. But here is what is, I'm going to give you some generalities and then some specifics from different state websites. So whenever a medical assistant performs a skill, he or she is doing so under a doctor's supervision, period. That's everywhere, so that hasn't changed. The doctor assumes responsibility for whatever the medical assistant does, but there's also a gray area that could leave your medical assistant open to litigation because the doctors could tell a medical assistant to do anything, but if that doctor or physician is out of line by telling their MA to do something outside their scope of practice, if you will, then they may be liable for doing something that they're not qualified to do. So here's some research that I did, and I looked at about 16, 17 states, and there was some consistency on what a medical assistant can do without any supervision from a doctor or nurse. So prepare medical records, maintain patient charts, order supplies, maintain medical office equipment, manage money accounts from patients, schedule appointments. They can also prepare, which actually, just to back up a little bit, that's very administrative with a little bit of medical influence. But they can also prepare instruments for exams, prepare exam rooms. They can record vital signs. Okay, that was actually part of an AMA discussion recently. They can assist doctors during certain procedures and certain minor surgical interventions, but you check in your state because, for example, in California, a medical assistant cannot assist with a minor procedure, but in Texas, on a limited basis, they can. So a medical assistant can also collect specimens. They can collect things like urine, blood, sputum for lab tests. They can perform stat screenings under the direction of a physician or qualified professional, but not independently. Okay, remember they can't do independent anything. They can relay questions from a patient to a doctor by phone, and they can transcribe dictated medical documents for the doctor, and they can relay lab results, but they cannot provide any interpretation of them or any advice to the patient. So if you take anything away from today's podcast, there's one thing that you absolutely have to take away. Medical assistants cannot treat or diagnose patients. Let me say it again. They cannot treat or diagnose a patient. Can they educate a patient about a diagnosis that a doctor has given or perform a prescribed treatment? They can pass along information, but they cannot do this independently or on their own. So medical assistants cannot assess, plan, or evaluate a patient or their care. A doctor or nurse has to examine a patient to determine that plan of care for them. So they cannot interpret test results. They cannot advise patients about their medical condition in any way. They cannot give, in many states, IV medications, but check on those states. There are a couple that will allow it. They cannot administer anesthetic medications for the purpose of putting the patient out. They cannot prescribe or refill medications independently. It's not within the scope of their practice. Can they call in a refill if the doctor has ordered them to? Yes, but they cannot prescribe on their own. They cannot perform physical therapy except in an assisting role. And they cannot perform any procedure, technique, or treatment that would constitute the practice of medicine. Where do you find some of this information? Well, the State Board of Medicine and the State Board of Nursing assists with medical assisting scope of practice. And again, if anything should go wrong, the responsibility falls on the physician. So an example, in Nevada, a medical assistant was sued for illegally administering medications. There was not enough information saying that it actually came from the physician. In New Mexico, for example, medical assistants have to be trained to use equipment before they can be reasonably delegated the responsibility of using it. And even then, it cannot be invasive equipment. In California, medical assistants are not allowed to perform invasive procedures such as placing a needle, starting and disconnecting the infusion tube and IV. During a minor surgery, can they assist? Only by handing the physician surgical tools they need, such as scalpels or scissors, or setting up a sterile field by gathering sterile packages and tools. And they can clean the surgical site with iodine or chloroquine solutions, but be clear, they're not allowed to make lacerations with a scalpel. So if there is a mole or wart to be removed, or to drain an abscess or some kind of biopsy, the only time they can pick up a scalpel is to hand it to the physician. And every state has their own ideas about what a medical assistant can reasonably do within their scope of practice. So I'm bringing this to your attention because you are open to liability if you don't know your limitations. So make sure that you do your homework. Make sure that you learn the scope of practice in your particular state for your medical assistants, and have this in a compliance manual to easily refer to if you're ever asked to prove what you were doing for that medical assistant, and making sure that it is legal and appropriate so that you don't get caught in a mess. Because they'll say, well, this is what I was told I could do. How many times have some of you changed jobs and said, well, we've always done it this way? Well, who told you that? Well, the person used to be here. You need to have a white paper compliance manual of how you handle your staff, and medical assistant should be number one. Just to get you started, make sure that when you come up with your compliance manual, that you have, first of all, the definition of what a medical assistant is, the task that they're allowed to perform in your state. And you can also go to aama-ntl.org, and that will help you with the state scope of practice laws. Again, aama-ntl.org, and that is the American Association of Medical Assistants website. And then also the legal principles. So make sure you're establishing these acts and regulations and policies and put it in your personnel file. And then also make sure that you're looking at the difference between verbal orders and then also orders that are standing orders. So what are they allowed to do? And make sure you know that as well. What they can refer themselves to. So they cannot do the office nurses versus doctor's nurses. That's a violation of the Nurse Practice Act. And State Board of Nursing. Oh my gosh. It'd be kind of like an RN also trying to call themselves an NP, a nurse practitioner. You want to talk about some whistleblowers? Try dealing with a nurse practitioner who thinks an RN is using that as the same licensing personnel. You'll see their head explode as well. So this is just more of a heads up to make sure everybody's compliant. I know we all use medical assistants and we need them in our practice. And so because we need them, we may need to make sure we're doing it right. And this has just been a major blip on my radar lately that we have to bring to your attention. So my coding question for today has to do with screening for diabetes and the diagnosis R73.03 for prediabetes. So screening diabetes, these encounters, you really have to be accurate because this is really part of preventative care, and it shows that you're taking really good care of your patients. But I'm noticing there's some overcoding going on here, and you have to realize there kind of is a downstream effect if you code this incorrect. So for example, if a patient is diagnosed with prediabetes, you report it again with R73.03. If a patient has a hyperglycemia in the emergency room and the doctor does a rule out to make sure they don't have diabetes before initiating treatment, it is vital to use the correct code to avoid erroneously miscategorizing the patient. When it's just an abnormal glucose in a patient who does not have diabetes, again, the R73.09, which is, it should be R73.09, which is other abnormal glucose. But keep in mind the big picture. So what happens if you erroneously code E11.9, and that's type 2 diabetes without complications? So that you're placing a patient into a diabetic category that not only puts the patient into a risk adjustment category that's incorrect, and you're going to have to recapture that year after year from a quality standpoint. And people are going to say from a payer standpoint, you have to make sure all your diabetic patients have an A1C check every year, they have their eyes checked every year, and their kidneys checked every year. So, payers and providers are really collaborating and reaching out more to better educate and manage patients who do have diabetes. So if a patient doesn't have diabetes, it's only pre-diabetes, now you've created a problem for the provider who is asked to recapture it year over year, the payer who's responsible now for these quality metrics, but now you're creating an abrasion with certain payers and members, let's say of, HEDIS or STARS, and now the patients are having a problem with that because now they're also going to have issues with pre-existing condition. So you have to be very careful when it comes to diabetes and make sure that if it's, it's no longer classified as controlled or uncontrolled. And so you have to know the difference between the different diabetic diagnoses as well. So just be careful with that. I see the pre-diabetes and the diabetes just kind of default used a little bit too much when the doctor just puts in DM without actually doing some research on what would be the accurate diagnosis. So be very cautioned with that, or that can be an issue. Our coding question today is brought to you by Gold Bond Ultimate Skin Therapy Lotion for skin that's nourished, healthy, healed, and healthy looking. Non-greasy, hyperallergenic, fresh, clean scent. Try the aloe healing kind. Gold Bond Ultimate. So for my personal tidbit this week, so for those of you that know me, I'm not a big drinker, but I like to have, for the holidays, a signature drink at my table for Thanksgiving. So I think this year I'm going to do a white sangria. And again, I do not like white wine at all. I think it tastes like Ivory Liquid dishwater. But I found something that I can tolerate, and a lot of my friends like it, and a lot of my family likes that. So we're going to do something, and this is just a little hack for it. So it is a pineapple juice, some pineapple chunks, some orange slices, a little 7-Up. Don't use Sprite, it's too sweet. And then a splash of your favorite white wine in there. And you can just use a quarter cup. Put it in mason jars. That way we're still for those of you that are still in the mindset of not sharing too much food and stuff. If you want to put it in a pitcher and pour it out for everybody to have, that's totally up to you. That's fine. I'm still a little germophobic right now. Even when we, go to dinner, I know last night we went out to dinner with some friends and we shared an appetizer, but I make sure that the appetizer is like spooned onto everybody's plate. You get your own chips, if we're doing some kind of a spinach dip or something. I just don't like everybody sharing still. I'm not there yet. As you know, my birthday was last month and it's been celebrated a couple of times with my friends and family. And they brought out a platter of like different fun, tasty things with candles in them the other day. And I said, oh, my birthday was last month. And I said, so am I supposed to blow this out all over the cake and cheesecake and then you guys are going to eat it? I mean, it's things we've been doing forever, but you're kind of like, maybe those traditions should go by the wayside. Have a little cupcake to blow out your candles and then don't blow on people's food. That's all I'm saying. That was just a weird kind of concept because we've been so much into the distancing, the masks and, the vaccines and all that kind of stuff. So I'm rolling my eyes right now because, it's fatigued right now. But anyway, if you're looking for any kind of signature thing and you like pineapples and you like oranges and you like the citrus, just try that. So again, use the canned pineapple chunks with that juice instead of actually bought pineapple juice because it's a totally different flavor. and it makes a great sangria for everybody at the table. But anyway, everyone, make it a great day, a great rest of your week. My Steelers are 5-3. We will come into first place if we can win on Sunday, so I'm pretty excited about that. So again, make it a great day, a great rest of your week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.